is it possible to define which is the minimum intake per week that will protect a person?
Well, yeah, they have looked at that, and it's basically 5 out of 7 is probably the minimum intake when they looked at the population. Yeah, so if you take it 5 out of 7 of your pills in the week, you're probably going to be protected. But the only caveat on that is, I think if you first start PrEP, the first couple of weeks, I'm not sure whether that 5 out of 7 rule would apply. But once you're in steady state, I think Bob Grant's group and all those people, they presented at CROI, not this year, the year before, on that data from PK.
Okay, and because soon the tenofovir will become available as a generic, are there any data about the combination of 3TC generic, tenofovir generic that could be as protective as Truvada, or shall we speculate that this will not be the same, or what are your thoughts?
Well, the only group that ever to me, I know there's data out there, but there's the biggest cohort data is in HIV patients looking at tenofovir FTC versus tenofovir 3TC with non-nukes and showing there's some difference, but not with PIs. I think a lot of that's all cohort bias. I've got no doubt that both of them will be effective. I mean, the half-lives are a bit different, but the intracellular half-lives are probably enough. And elsewhere in the world, lots of people are taking generics with a Feverence 3TC tenofovir. That's been made, so and they're remaining undetectable. So I don't think there's going to be a big issue with that.
Yeah, just to comment on that, as you say, Anton, I think daily tenofovir 3TC should be fine. The question is, will 4 doses a week, similar to Truvada, be coverage as well? I think it'll be very difficult to show a difference. I think you might need huge numbers. Marta maybe later will comment on it, but I mean, the drugs are similar enough that should not be. In fact, we don't even know, how much added benefit the M-tricidabine on tenofovir. It's giving some. We've seen that in studies, but clearly you'll be splitting hairs. So I think your idea, Ventura, that as Anton was saying, money, money, money. If you can, until we get the M-tricidabine, I think the lamivudine will be a very good option for folks. Do we have a question in the back?
No, it's okay. I understood the question being answered.
Okay. So, other questions? If not, I'll also bug you with question here. Oh, there. Let's give you a microphone. It's microphone 1, please.
I was wondering if there is any research or hope for the injectable PrEP, like the ARVs.
Yeah. So there's a study called the ECLAIR study using cabotegravir, and it was presented at IES. So you can download all the slides from IES, well, most of them. You can download and have a look. I haven't gone into that because, as I said, I'd be there a long time. So basically, they found that the PK is good if it's taken every 8 weeks. So it's going to be about 8 weekly that you'll take cabotegravir. If they tried it every 12 weeks, and they got some breakthroughs with resistance, so it's every 8 weeks. But as I say, that's all work in progress, let me say. And I think I didn't mention all the drugs. Maravirock's been used and other drugs, etc. So as far as the injectable is concerned, that's the furthest on. People have used antibodies as well. That's another bit for PrEP, antibodies for PrEP. And as I say, that people are working on an implant. So there's quite a lot of things coming forward. But we've time to wait, I hope.
Do we have other questions here? Oh, again, microphone 1, please.
So it's more common than a question. And so in France, we have all these PrEP, people who ask for PrEP. But we are some infectious disease, and we spend a lot of time with the people who want to have PrEP. And we see them every 2 months or 3 months. And there's so many people, at least in Paris, when you work next to the Marais, you spend more time with the guys who are not sick.
Yeah. Okay.
This
I
is
know.
a big point.
So this is all about how you guys have got to redevelop, like we've had to do. You have to redevelop the service. Because what happens is maybe the first time they see a physician, and after that you can have people who are just going to monitor them, and you don't need to have a physician who's gone to medical school for 5 or 6 years, done a postgraduate degree, done something else, been 20 years in the field, to see someone who says, "I'm fine, here's a prescription," right? So you have to. I mean, Africa's doing this now. Africa's completely devolving models of care, and I think that in our clinic we have nurse practitioners and other people that do this stuff. And I think for PrEP, I would really try, and my feeling is to keep it under your infectious disease branch, but tell people that you need others to deal with it. And if you don't have enough staffing, apply for funds and say, we're now looking after a lot of prevention.
The question is, so I think it's a great point, and it really comes to mind, Anton, and when you speak of this, the data are compelling. Compared to other things we do in medicine, I think you said number need to treat at 13. Where in the world do we have that? I mean, it's compelling data, and we have so many huge studies. I think, part of it is this issue, who should be responsible for this? We're sort of ID docs in the room, but this is a general practitioner. This is a family physician. And I think part of it is that, maybe our role here is more to educate our colleagues than to be the one, right? I mean, basically, as you said, if I were a family doctor and you told me about this and I read up about it, I should be asking my patients some questions. And if they answer positive, I should have a nurse or a nurse practitioner or even someone very, that I refer them to. And they organize the whole thing. Yeah. It's a healthy population. Mm-hmm. It's a safe drug. The monitoring is straightforward. I think the logistics of organizing our clinics, and I think, something we think about, both these points, and what you guys are doing basically, since when does a doctor say, go to the internet, fine. But these are things where probably as a super ID doc, you don't necessarily have to be doing that. You have to set up in your country. I would think that giving I've always been tempted, to give a talk to primary care physicians about this talk, and say, we'll provide you the information, and if you have a question, but we should hand it over to the community, because that's maybe where this needs to be done. It's a great point.
In France, for example, it's forbidden. You have to go to your ID doctor. But in the other hand, we are treated a lot of syphilis and gonorrhea and chlamydia. So this is a good point, but still, we have two hands. So
laws can be changed, as we know.
Let's move to our next.
So, Anton, we'll bring you back for the discussion. Thank you very much, and I'll hand it over to Ventura.